Okay, welcome everybody. My name is Stephanie Landon, and we are so thankful for you to join the Histiocytosis Association of Canada's very first webinar titled Ask a Histio Expert, Exploring HLH. Now, I realize we'll get to it, but I realize I don't actually have full viewing of all my controls, but we will handle it first. So as I said, my name is Stephanie. I am a director on the board of the HAC, and I will be acting as this afternoon's moderator for the webinar today. This is welcome introductions. This is me. Hello, hello. Just a really brief little introduction about myself. I became involved with the organization when back in 2015, when my 8-week-old son was diagnosed with HLH. He went on to have not one, but 2 stem cell transplants, and I'm really happy to report that he's doing very, very well these days. He's 6 years old, but that is how I became involved. So I'm hopefully probably walked in the shoes of many of you who are joining tonight. Okay. Now, before we start, I wanted to walk through some considerations. Tonight, we will be hearing from Dr. Michael Jordan and Dr. Ahmed Naqvi, who are going to be very graciously sharing their insights and their expertise. But I want to remind everyone that the content of this webinar is their opinions, and the information provided is not intended to replace medical advice or guidance. So if you have any questions about your treatment or anything specific, please be sure to speak to your doctor. Tonight's forum is really to kind of address general questions. I also want to give thanks to both SOBI Canada and the Histiocytosis Association for their help with making this webinar happen tonight. It's through their support and generosity that we were able to have you here, and we want to say thank you so much to them. A couple of Zoom reminders. I know it's 2021. I bet you everybody knows this like the back of their hand, but if not, there's really 2 functions I want to make aware of. The first is the Q&A function, which is where you can submit your questions for us to look at, as well as the chat function, which is where if you're having any technical issues, you can submit them in our wonderful team at the Histiocytosis Association will be able to help us out and help you with those. Now, I will say, in most cases, if you're having issues or if you get disconnected, please just try to log out and log back in using the registration link that was in the original email. Now, I'm going to put the AJ on the spot. I actually think I need to pass over my controls because I'm not able to see the Q&A bar, and I believe, so Dan, I'm putting you on the spot, but do you mind taking over control to see if I can see it? Please, thank you. There we go, perfect. Okay, that's excellent. So Deanna, you're gonna have to control. I'm gonna tell you next slide if that's okay, but this way I can see all the wonderful questions that we received tonight, which is, I believe, quite important. Okay, so I am really excited to introduce today's guests. I'm going to let you know who they are. I'm going to tell you a bit about them, and then I'm going to take a moment after this to introduce some other members of the HA and HAC, and then we will kind of delve into the presentation portion of the webinar. So today, I am so delighted and appreciative to introduce Dr. Michael Jordan and Dr. Ahmed Naqvi. Dr. Jordan, as possibly many of you know, I know I certainly know the name, is a member of the Division of Bone Marrow Transplantation and Immune Deficiency Division, as well as a scientific director of the HLH Center of Excellence at Cincinnati Children's Hospital in Cincinnati, Ohio. He is known for his dedication for an understanding and treatment of histiocytic disorders, as well as the novel new therapies that treat them. So we thank him for joining us today. I also want to introduce Dr. Ahmed Naqvi, who is a staff hematologist oncologist at the Hospital for Sick Kids in Toronto. Dr. Naqvi has a special interest in HLH, and he's actually currently the co-director of the histiocytosis program at Sick Kids. He also coincidentally was my son's doctor back in 2015, so this is so thrilling to have both of these wonderful gentlemen here tonight. Now, Deanna, if you don't mind advancing the slide, please. Perfect. So before we start, I would like to introduce our president, the HAC's president and board board member Claudio Di Girolamo. Claudio joined the HAC after his daughter was diagnosed with HLH in 2018, and I want to hand it over to him to tell us a bit about our organization. Hey, Claudio.
Great, thank you, Stephanie. Thanks for having me, and thanks to everyone in the audience for participating this evening. Obviously, this is our first, hopefully a long series of webinars that we're going to strive to educate and continue to advocate in order to raise the awareness, the required awareness for the families that we support. If you're on this call and you're participating, it's because you've witnessed what this disease does and how quickly it does what it can do. By the grace of God, we were fortunate. My daughter, who suffered HLH secondary as an adult, is still with us, and I want to say hi, Claudia, because I think she's watching this evening. This is something that, band together as a group, we can affect change. Our abilities as an association are only as good as the participation that we get from everyone involved. And as a volunteer organization, we strive to ensure that your voices are heard, that there is an avenue for you to seek advice, for you to offer your opinion, and to talk to someone. And that's something that we do and that we strive to continue to do every single day. There is a website that you can go to, the histiocytosis.ca. We encourage everyone to donate to the capacity they can and to help us find some advocacy for this disease and to bring some solace and comfort for the families affected. I want to thank Dr. Jordan and Dr. Nakvi for attending. I want to thank the board members for supporting this, and to Sobeys for endorsing us and supporting us through this webinar. So with that, I'd like to introduce hand this back to Deanna, represents the HA, and they've been instrumental not only in our nascent journey into this webinar, but also in providing us guidance. They're a tremendous organization, and I know personally it's an organization that I looked to when my daughter Claudia was going through her illness. So I'd like to introduce Deanna. Deanna, I'd like to turn it over to you.
Thank you so much, Claudio. Thank you, Stephanie. And thank you, Dr. Jordan and Dr. Nakvi. We truly appreciate the opportunity to partner together. I just wanted to share how much we are thrilled for your partnership. We know how much you do for patients and families. You have funded some tremendous research advancements. And I know the organization also provides emotional support, connection, education for those impacted by all histiocytic disorders within Canada and around the world. So we're just thrilled to be able to be here with you today, and I'm looking forward to the webinar and future talks to come.
Great, thank you so much, Deanna and Claudio. Now, this is the fun part. I am going to introduce Dr. Mike Jordan to speak a bit about HLH. So Dr. Jordan, you should have control of the slides. Thank you so much.
Okay, great. Can you hear me all right? Yeah. All right. Yeah, thank you for the invitation. I'm always happy to speak to families in this sort of context. So hopefully this will be informative and educational for those on the call. So I'm going to talk a little bit about what HLH is, and then a bit about medical progress. But of course, this is a brief chat, so I think we'll address specific questions afterwards. So I'm going to see if I can advance the slide. It doesn't actually want to advance for me. Oh, there we go. Now it's advancing to me. Yeah. Okay. So okay. Right. So, this disease, right, has this funny name, and I think it's informative to sort of dissect this name, right? So hemophagocytic lymphohistiocytosis, or HLH, right? Hemophagocytic, really, if you break it down, it really is referring to blood-eating cell, right? Hemo, phago, cyt or cyte, right? Associated with an expansion of lymphocytes and an expansion of the eating cells themselves. And really what this is referring to is that lymphocytes and histiocytes are immune cells that are really essential parts of your immune system. They normally work together to help give you immunity to infections. But in HLH, they really sort of expand in an uncontrolled kind of way and form what I think is best described as an angry mob that causes damage to patients' bodies. And so in many ways, so a normal immune response might be a small fire. HLH is like a forest fire. And it's really best to think about it as a syndrome or a pattern that we can recognize clinically. It's really uncontrolled body-wide or systemic inflammation. And when we think about HLH, I think it's informative because it can be kind of confusing and to sort of try to understand what physicians are referring to, and even for physicians sometimes what we mean. And so what we mean at the surface is there's a pattern that we can recognize that a patient may experience. And this pattern is listed right here in the small text. You don't have to read it, but this is sort of the criteria that were established now some years ago for an international clinical trial to come up with a sort of a uniform definition of what do we mean by somebody that has HLH. And this pattern was defined to try to, developed to try to describe what do children look like, usually young children that have a genetic predisposition to HLH when they get sick, kind of what sort of features do they develop. So the details are not really important, but the point of this that I wanted to bring up here is that underlying this pattern, right, there are specific causes or triggers. What this pattern is most intended to identify, but actually identifies more than this, is those individuals that have a genetic predisposition for the immune system to sort of spin out of control in a very specific kind of way. And what this is referring to are, there's a group of genes that you can sometimes group together as causes of familial HLH. But it's also true and increasingly apparent in recent years that there are a number of other immune regulatory disorders with distinct genetic causes that themselves are more rare causes of HLH, but they can from time to time also cause HLH. And so you have this underlying sort of genetic predisposition. But then there's this other category, and the sort of the genetically sort of predisposed HLH is sometimes called primary HLH. There's this other category that people refer to as secondary HLH. And what that means is that you develop this same pattern, but you develop in the context of a very specific condition that condition itself, perhaps instead of your genetic heritage, is actually what predisposes you to develop HLH. And these other conditions I'm referring to are cancer, sometimes known cancer or cancer that hasn't yet been identified, or rheumatologic diseases. And when HLH occurs in the context of a rheumatologic disease or diagnosis, then it's often called macrophage activation syndrome. And that kind of reflects history and different specialties, but they're very similar. So I think a fair way to put it. Now, what about infection, right? Well, in fact, infection is seen in both situations because oftentimes, oftentimes somebody may have an underlying genetically sort of encoded predisposition for their immune system to get a little bit off balance, but it doesn't get off balance unless it's triggered in the right way. And the thing that triggers it, we can't always find triggers, by the way, but the thing that often triggers it is infection. So you may have you may see an individual that has genetic primary familial HLH, but in fact it's triggered by an infection. There may be other situations where somebody who, for instance, has rheumatologic disease such as systemic onset juvenile idiopathic arthritis, and when they get an infection that triggers HLH or MAS in that individual. So infection is kind of ambiguous. And of course, there are sometimes and this isn't rare, but it's sometimes we see patients that don't have an identifiable genetic trigger and don't have a really clear specific condition that's sort of the context in which it arises. And so all you might have is an infection. So the infection itself might be the trigger or the cause. But that's really what we're referring to when we're talking about what is underlying HLH and these different sort of classifications. So amongst the genetic HLH patients, the genetic causes come in largely two forms, or for the most part, two forms. And those forms are either what we call autosomal recessive, meaning both parents are unaffected carriers, and a fraction, typically a quarter of their children would be affected. Half of their children would be unaffected carriers of those traits. Alternatively, there are some disorders, and they're actually listed on the slide here, that are what we call X-linked, meaning that the gene is actually on the X chromosome, and girls inherit 2 copies of the X chromosome, boys inherit 1 copy. So what tends to happen is that only the boys tend to be affected. though that's not a 100% hard and fast rule. Okay, so a few slides about HLH treatment. So the overall outline of HLH is the first thing you have to do is you have to put out this fire in order to gain control of the situation. Because patients oftentimes, as many of you may be very well aware, get sick very fast, very suddenly, and very urgently. And so that you have to do something to put out the fire. And once the fire is under control, then something needs to be done to prevent the HLH from coming back if, for instance, it's due to an underlying genetic cause that predisposes somebody to have recurrent episodes. And that's something you have to do is actually replace the immune system with one that doesn't have that sort of underlying problem. And so, and so the most standard way that HLH is treated around the world is sort of illustrated by this diagram here. And this is maybe a little technical, but basically what physicians tend to utilize is a chemotherapeutic drug called Topocyte, as well as another anti-inflammatory medicine called dexamethasone. And you start kind of really high and hit it really hard, and then you kind of back down. And you do that over the course of a couple of months. And that is, the idea there is that this sort of therapy isn't ultimately sort of tolerable for a long period of time, but you want to hit the disease hard and fast and then sort of slowly back down with the hope the disease doesn't come back. So it actually fairly frequently will flare up while you're trying to back down on the therapy. Additionally, if somebody has involvement of the brain or the central nervous system, then they also may receive spinal taps where medicine is instilled that is the medicine is anti-inflammatory that can potentially help control that disease. So, however, that's the traditional standard approach, but there is truly a proliferation of options now for treating HLH. So over the last 10 or 20 years, it's become increasingly obvious sort of the immunologic sort of underpinnings of the disease, exactly what kind of problem is actually occurring in patients. Historically, it was really a complete and total mystery. And so it was almost by accident that it was discovered that throwing chemotherapy at the disease is actually beneficial. But we were getting smarter about how to actually control the immune system in the appropriate way. And so I don't know if you can see my pointer. I actually probably can't on your slide, but as you look across the top of the slide, you can actually, yeah, Stephanie, okay, oh, excellent. So if you look across the top here at Topocyte and corticosteroids, of which dexamethasone is one of several, these sorts of medications, they act by suppressing these sort of key features of the immune response. So remember the name hemophagocytic lymphohistiocytosis. Well, it turns out it's CD8 T cells are a type of lymphocyte that are really important. And amongst the histiocytes, macrophages are also really important. And the topocyte tends to sort of destroy the activated lymphocytes that are most relevant. And corticosteroids tend to sort of soothe things by acting across both the lymphocytes and the histiocytes or the macrophages. And that's the conventional approach, but it is associated with a lot of side effects. It's not effective for everybody. So there are other approaches. So newer or non-conventional approaches include antibodies against the lymphocytes. And those are either what we call ATG or anti-thymocyte globulin or alemtuzumab, also called Campath. And those medicines can be effective. There's the other strategy is to block interferon gamma, which is this major mediator between the lymphocytes and between the histiocytes that tends to drive the disease process. And in the US, at least, there's a drug approved called Evapoliban that directly blocks interferon gamma. There are other drugs that can block the signaling of interferon gamma in the histiocytes, as well as other cytokines, because these cytokines signal through molecules called JAKs, and these drugs are called JAK inhibitors. And so one drug that's been utilized in patients is called ruxolitinib. And then there are other cytokines that are important in this whole swirl of inflammation, including IL-18 and IL-1, and there are specific drugs that can block these cytokines that are utilized either experimentally in the context of a clinical trial, such as tadakinumab, or are available for physicians to prescribe, as they deem appropriate, which would be describing anakinra. So there are increasing options. So this is a really good thing. We have more flexibility in terms of how to best treat patients. It's also a little more complicated to try to explain and decide exactly, explain to families and decide exactly how to proceed. So, but I'll just give you a few words about Evapoliban, because I think that is, the biggest sort of solid news of recent years. And so Evapoliban is an antibody against this molecule called interferon gamma. It blocks the ability of this molecule to do what it normally does. And interferon gamma is a really important molecule that the lymphocytes use to tell the histiocytes to basically get angry and to cause trouble. And it's important for being able to control certain infections such as tuberculosis and a number of other sort of, what are in modern days very rare diseases. But it does have very specific functions that we, that may be important if somebody has those specific infections. But it also tends to make patients very sick. And we discovered many years ago, at least in experimental context, that that it's a really important cause of why patients get so ill when they have HLH. And so there was a international clinical trial that was conducted, and we published about a year or so ago. And on the basis of this trial, the drug was approved for use in the US. And on that trial, about 2/3 of patients showed evidence of a response to this drug. And the patients that we enrolled were mostly patients that had failed standard therapies or really couldn't tolerate the standard therapies because of the side effects. And so they were enrolled on this trial. And these are the sort of the long-term results that we saw. And that is that, so this is a difficult group of patients because they were not, just even the average HLH patient. They were the HLH patients that were having special trouble. And so despite that, though, about 70% of the patients were able to survive long-term. And, quite remarkably, about 90% of the patients actually survived after bone marrow transplant, which is better than expected. And so we're very happy with these results. And as I mentioned, this is not approved yet in Canada. It's not approved in Europe. So this is still an unfolding, an ongoing story. There is an ongoing trial testing this drug in patients with rheumatologic diseases. And so I think there's more to come there as well. But in terms of other new developments, so as I already mentioned, Evapoliban has been tested in HLH, is being tested in MAS, and we're hoping to start relatively soon a trial to really look in terms of what effect it may have in bone marrow transplant. And ruxolitinib is currently, well, it's been utilized by sort of sporadically by physicians here and there. There was a trial that's starting in the US, and I'm not sure if it's going to open. Maybe Dr. Nakvi can respond to that. It may open as well in Canada to really specifically test ruxolitinib for the treatment of HLH. Alemtuzumab, that antibody I mentioned, there's a study that's completing in France right now. Tadakinig, the one molecule I mentioned that is important for a subset of patients with HLH, there's an ongoing trial testing tadakinig as well. Okay, so a couple more words here. I realize I'm running long, so hopefully not too long. Just a few words about bone marrow transplant. So really I was focusing on just now was how do we control HLH? Once we have HLH under control, then really we need to prevent it from coming back. And so ultimately, if somebody has familial, genetic, primary HLH, then they need bone marrow transplant because the disease, once you control it, it will come back. And so after we get control of HLH with the therapies I was just describing, it's important to really to cure the problem, and that's by replacing the sort of the damage or the broken immune system. However, the problem is that when HLH is active, patients are so sick, it really makes bone marrow transplant very difficult or impossible. And even when patients are well treated by the therapies we currently have, bone marrow transplant can still be more complicated for these patients than for other patients. And so it's also important to recognize that bone marrow transplant is risky. And so it's really only a good idea if we can confidently predict that the HLH will come back. And as I mentioned at the beginning, there are still plenty of patients where we don't really know exactly what the cause is. In other words, we don't find a genetic cause. They don't have a cancer, for instance, and maybe they don't have a rheumatologic disease either. And so we're left guessing sometimes. And so it's still a little bit of, we have to wait and see how things go to make these sorts of decisions. Also, it's worth noting that MAS, that is HLH in patients with rheumatologic diseases is usually lower risk. And so bone marrow transplant is really not appropriate for most of those patients, even though they may have more than one episode of MAS. Okay, and so with that, I think I will hand it back over to Stephanie.
Thank you so very much. That was incredibly informative, insightful, and really helpful. Thank you. Yeah, so I'd like to, at this time, open the floor up for our interactive Q&A. I may have mentioned, I hope I mentioned it previously, that we received a lot of questions from registrants when we signed up for the webinar. So I have them kind of jotted down here. I will basically pose them to both Dr. Jordan and also Dr. Nakvi. Dr. Nakvi kindly is going to join us for this portion, and hopefully we can get both a US and a Canadian kind of angle on some of these questions. So what I will do is, unless I have a specific questions for one of our doctors, I'll point you out, but otherwise I'll let you maybe decide amongst yourselves who wants to answer, okay? So I also want to mention again before, we did receive a lot of questions. In the event we aren't able to answer a question you submitted, please by all means email us at info@histio.ca or share with us on Facebook, because we will, try to help you out offline after the webinar. So to begin, we received a lot of questions about kind of HLH recurrence, HLH coming back, and it really is a good segue from Dr. Jordan's discussion about a cure, specifically for adults who have secondary HLH. If they've been in remission for more than a year, will it ever come back? Is it, wait and see, the longer you go, the less likely it will be, or is it always kind of a watching and waiting situation? Who wants to speak to it?
Yeah, go ahead, Mike.
Yeah.
Okay, yeah.
They will tell who's going to answer.
Yeah, he was tossing me this hard one. This is a hard question.
Is it? Okay.
I think it's worth pointing out that I think we can identify an underlying cause of HLH in a majority of children. However, in adults, the spectrum is a little bit different. So where in children, I think, depending on the situation, you could say probably more than half of them we can find the genetic cause these days. In adults, it's a very tiny fraction that will actually find a genetic cause. And so what do we find is underlying causes in adults? Well, what is most commonly found is cancer. And then the other thing that can be found, of course, and this is not usually a surprise, it's often known already, is a rheumatologic disease. So if the question is referring to an adult who has not been found to have cancer and who does not have a rheumatologic diagnosis that's obvious by now, right, a year later, then we're definitely in sort of kind of mysterious territory, right? I would say if I saw somebody like this in my clinic, I would say that if they don't have evidence of inappropriate going on right now, then I would feel pretty good that it's not going to come back. However, I would be very open about the fact that there's a lot we don't know about the situation, and it's very difficult to predict. And so I would, with a very in a very tentative way, I would say that that I would, after a year, I would say I would feel, if there's nothing that's come up as a cause, then I would feel fairly positive about the risk being relatively low.
Thank you. Dr. Nakvi, anything to add to that, or?
No, that's fine. I think as we see that with those conditions where there are like rheumatological conditions, which each reactivation, there can be MAS type of a picture that re-emerges. But if there is no underlying cause, then we have seen that it goes, and then we keep following our patients for secondary HLH as well, and hardly it ever comes back.
I can appreciate how difficult it must be to answer some of these questions. I know from our family's experience, I think every time we saw our doctors were like, can you tell us, because we always want to know what to expect next. So I can understand it's probably different case by case. Kind of thinking to the pediatric side of things, this is a question I had myself, but it was submitted through our registration. After a successful BMT, would you use the terminology that patient is cured? Are they cured of HLH? Or would you say they're in remission? Is it safe to say that someone is cured after a bone marrow transplant, a successful bone marrow transplant? And what's success?
Yeah.
Yes.
Dr. Nakvi, maybe I'll start with him.
Yeah, we'll call it as a cure, because the thing is that immediately after transplant, sometimes we see that the bone marrow actually, we call it as chimerism, and in some cases the chimerism goes down. But there can be at that point that if the chimerism goes below a certain number, then of course there can be reactivation. But again, there are ways of treating that. But most of the time after transplant, we call it as a cure. It's not just a remission; it's a cure.
Okay. Great. Okay. Now we received some questions about flipping to kind of the genetic, because I know we just received one on the Q&A, and also we received others about kind of the genetic side of things. I think you already answered, you touched a bit on this in discussion about whether HLH is always genetically linked. I think we know the answer to that. But I remember someone asked how many genes have been identified so far. And another really good question I thought was, does the gene that the mutation is found on indicate disease severity? Like, are some genes more severe than others?
So in our HLH gene panel that we do, we are actually, I think in Cincinnati as well, there are 16 gene panel that we are doing it right now. But there are so many other genes with primary immune deficiency that they are coming up now. So I think if you talk to us about the typical HLH panel, then we are looking for 16 genes or so. And about the severity, yes, there is some association with gene abnormalities. Like there are certain mutations which present which present earlier in life, and maybe there are some which are less severe. But there's no hard and fast rule. How would you add anything, Mike?
Yeah, no, I think that's a pretty good summary. As you might imagine, some mutations are in the same gene would be more severe than others, and some genes are probably more troublesome, more problematic to have them disabled than others. And so it's hard to have a real sort of hierarchy, you might say. The only thing I would say beyond that is that the list I had on the slide, those are sort of the genes we most commonly associate with HLH. They are at least the ones on the, as you're looking at the slide on the left-hand side, they're all actually very related to each other, they're all in the same pathway. But there is an increasing variety of other genes that affect the immune system in a variety of different ways that can lead to HLH, perhaps individually somewhat more rarely than the ones I listed on that slide.
Okay, thank you. We received another question, which I'm not sure if it's related, but one of the questions was, how does HLH cause other immune deficiencies? I'm not sure how you would infer that, but
I would say that HLH is caused by certain immune deficiencies, but HLH by itself is not a cause of other immune deficiency. It's the other way around, actually.
Yeah.
Oh, interesting. Okay.
Yeah, I agree. I'd say it's a complication sometimes of immune deficiency.
Yeah, interesting. Okay. Okay, but switching gears a little bit, talking about kind of frequency of HLH. Is HLH on the rise? Now, we always were told it's a rare disease, but as we went through our, we were on that journey. I don't consider us on the journey anymore, but, for years, we always were told it was a rare disease. But it seemed like I knew somebody's brother or friend or uncle who had it. So is it considered still rare? And is it on the rise? Are we seeing more cases now than we have in the past?
It depends where you are living. In countries where consanguinity, that means that is cousin marriages are more and more, there are more chances of children to have, if it is in the family, then the chances are more. So in those countries, HLH is seen more frequently. I think the awareness is increasing. That is why we are seeing more and more cases of HLH. Previously, these children were not diagnosed. Now there is so much awareness amongst at least pediatricians at good centers that we start thinking of HLH very early on. So that's why we are diagnosing more cases. But of course, as I said, it is a genetic disease, and then where there is a pool of these consanguineous marriages, of course, there in those countries the incidence is much higher as compared to those countries where the consanguinity is less. Dr. Jordan?
Yeah, I don't think it's occurring more often, but it's definitely being recognized more readily, is a good thing, and being recognized much more often.
Agreed, that's excellent. I mean, that's a good progression to see. So, okay, we received a couple here. I also want to preface, thank you so much for submitting your questions. I don't know if I mentioned this, I apologize if I forgot to. We can only really answer questions in general terms, so we can't provide individual medical commentary. So when you're submitting your questions, please keep that in mind that unfortunately we can't answer specific personal questions. But I do see one here that is interesting. Is someone more at risk for HLH if they don't make the protein needed based off of genetics? So for example, XIAP protein if XLP2. I'm sure if that is enough, I'll leave it to you to answer. It doesn't quite.
Yeah, so what's often the problem when there is an abnormality in the gene is the protein is not made. Sometimes the protein is made, it just doesn't work. And so both can happen. It's hard to make a real generalization, but it's probably most common that the protein really isn't made, or it isn't stable, doesn't stick around. So I wouldn't attribute any special significance, good or bad, to say having a decreased level of protein. I think it's reflective of the underlying genetic problem.
Okay. Thank you. Now, I know you spoke about macrophage activation syndrome, or MAS. We're seeing a lot of acronyms in the news. I know with COVID, for me at least, it's been surreal to see kind of all these similarities in terminology and treatments and such. But we're hearing about MIS, or multi-inflammatory syndrome. Is there any link between that and HLH? Is it, even hearing about dexamethasone being a treatment, like, can you speak to, is there any, like, indeed any link between COVID and HLH?
Mm-hmm. So I have to be careful in terms of how I state this. I think it's fair to say that when the immune system gets really revved up, right, the things it does can be very harmful, very toxic. And so in that sense, yes, there are some similarities between MIS-C and HLH. But in terms of the underlying process, it is, I would not say that it's a sort of a HLH or a partial HLH. It just has some overlap in the sense that they're both kind of toxic, things that happen when the immune system gets going really, really strongly.
I will ask a follow-up question. Do you think because of this global effort to treat COVID, essentially, or the outcomes of COVID, that we'll see advancement in HLH treatments? Because perhaps there's some learnings to take from this global effort to invest in this condition.
I think there are some learnings. I would say that they're probably more indirect than direct, and it's still unfolding for sure. But we've learned a ton as a scientific community in a very short period of time about how the body responds to, in this case, a new virus. Okay. So now bridging over to kind of treatments again. You mentioned Evapoliban is not approved in Canada. So because this is a Canadian organization, a lot of our attendees are Canadian. I'm going to ask a general question of, is there any availability of getting access to this medication at this point? Is this something that patients and families should be asking for when they're undergoing treatment? And as a follow-up says, what else, was there anything that Dr. Jordan, not to put Dr. Jordan on the spot and Dr. Naqvi, but is there anything that wasn't mentioned that perhaps is available in Canada or we should be considering in Canada that might differ from what's happening in the US?
Yeah, so we have, so go ahead, Dr.
I was going to say, I'm gonna let you answer that one.
I was hoping Dr. Naqvi would answer.
Yeah, so We have it available on compassionate release, so it's not available otherwise. So we have used, and recently in another hospital also they got it on compassionate release. We have just finished, we were part of a study for Evapoliban on newly diagnosed patients as well. So that study has just finished enrolling patients. So hopefully once that results are also there, then we will be in a better shape, I think, for getting Health Canada approval. And yeah, so we have Evapoliban only on compassionate release. We have availability of ruxolitinib. Ruxolitinib is available, and of course some other which Dr. Jordan has mentioned. Yeah, we have availability as such, but not approved as yet.
Okay, thank you. Dr. Jordan, anything to add?
No.
Okay.
Actually, I do have a question for Dr. Nafri. Do you know, is the tadakinib trial open in Canada, and is it open at sick kids?
Yeah, it is actually. We have enrolled one patient recently. Yeah,
Okay.
it is yeah.
And again, from a patient lens, if a family wanted to learn more about how to get involved with clinical trials or these new treatments, what's their best method of getting that information? Asking the doctor or?
Yeah, so they can always, I mean, if there's a patient, at this point, there is no open trial as such in Canada. The one that was of Evapoliban has just finished enrolling patients.
Okay.
So at this point, there are no open trials, but if there is anyone which comes up, they can always ask us through Histiocyte Society that if there is any new trial has opened or not. And yeah, we will let them know for sure.
Okay, thank you. Again, thinking about Canada, we know that there are a lot of people who live in remote areas of the country who may not have immediate local access to, say, Sick Kids Hospital, which I know our family was very lucky to have. What would you recommend to a family who perhaps doesn't live near one of these centers and they receive this diagnosis? What would you suggest their next steps would be? Do you recommend that they move? You know, and then it doesn't sound so nuts because, you know, I know a lot of families who've had to do that. So do you have any recommendations for that?
Yeah, the thing is that it's not only Sick Kids that treats HLH. There are other hospitals also. So there are 16 academic centers all over the country, and 5 of those are in Ontario. And each center actually can treat HLH, and they treat because we exchange our patient. I mean, if there is any complications or any difficult questions, then of course we exchange our notes. So yes, they can go to any of those academic centers and they will be taken care of.
That's excellent. I do recall, you know, again, when our son was first diagnosed, how wonderful it was to hear that, you know, the community seems to share emails. They look at each other's cases. They'll spell in. That was so reassuring. So I hope that's continuing, and it sounds like it is. So thank you for that. Okay, moving down the list. Okay, if someone is taking immunosuppressants for an underlying rheumatoid condition, are they at greater risk or exposure to HLH? Maybe Dr. Jordan?
Yeah.
Give me the tough questions here. We come for the tough questions here.
It's you know, it's a hard one to answer with certainty. It doesn't appear, I would say that in general, it doesn't appear that being on an immunosuppressant necessarily makes one more likely to develop HLH or MAS. It's probably the underlying disease. But, you know, I have to sort of, you know, have the one exception is that, you know, if the immune suppressant makes it very difficult to control an infection, then you could think of a situation where it could actually kind of sort of help lead to HLH because the infection is so out of control.
Okay, thank you. Okay, another question we received is, how long is the incubation period of idiopathic HLH?
So the term incubation period is actually used for infections, from the exposure to the organism, whether it is a virus or a bacteria, to the appearance of symptoms. So that is the period which is known as incubation period. So for HLH as such, I don't think that there is any incubation period. There are some children who are born with the genetic defect and they do not manifest the disease for years together. Although majority will be in the first year of life, but there are some children who present late. So as such, there is no incubation period. Incubation periods are usually for infections.
Okay.
But if you say, if you are asking like the time to manifest the disease, that differs with different genes and different children themselves.
Interesting. So again, as an example, if someone who had a viral trigger, a secondary case, I guess, or maybe not even secondary, but if someone, would depend on the virus that triggers the HLH to determine that period of time where the symptoms come on?
I don't think so. What do you think, Dr. Jordan?
Yeah, I think I think this question, to my mind, I can only really answer it in the context of, you're born with a genetic heritage. If that predisposes you to a certain problem, when would that happen? And so I would say that the more severe genetic problems typically occur earlier. But there are mild ones where that have been described that repeatedly across multiple individuals don't appear until someone's older, even young adults. But those are the exception, not the rule. And this question kind of doesn't make sense if we don't know what the underlying trigger is. It's who knows, right? Excuse me.
Yeah, fair.
And if it's associated with something like a rheumatologic disease or a cancer, then it's probably not something where they tend to occur, together in time. So there's not usually a huge lag or a huge lag.
Okay, thank you. Okay, an interesting question here. I'll ask it. We have, thankfully, wonderfully, a global community that we're connected with, and I know that there are members or individuals attending tonight who live in different countries, but they raise a good point. Someone asked, is it possible if someone wanted to get, say, access to your expert insights, how would they go about connecting? Is there could they ask their doctor to email you? Is that the best way to, is it as grassroots as that, or is there, is it through the Histiocyte Society that patients should be asking to kind of be able to share case findings if they feel like your doctor, perhaps I'm not suggesting, but maybe some doctors don't have as much experience with it and they want to be able to tap into this larger community?
You're asking me or Dr. Jordan?
Either, both.
I mean, I'm fine. If you want to put my email address on Histiocytes Association site, then it's okay. Email is the best way to reach me. Yeah.
I was going to say, you can actually also, anybody can email the Histiocytosis Association of Canada, and we can also maybe make the introduction as well. Thank you. Yeah. But on a bigger scale, is it through, is there a hub, I guess, in the world where, is it the Histiocyte Society, I guess, where you're able to share this information?
Right. So the Histiocyte Society is is sort of a professional organization for physicians and scientists. In terms of family organizations, the Histiocytosis Association, when people email them, they have certainly forwarded on email requests to physicians in different parts of the world. In the society, we partner with the association, and so depending on where the request is coming from, it can be forwarded on to physicians, in many places around the world or in the U.S.
Okay, thank you. Yeah, so I think we're hoping if anybody has any inquiries about that, my recommendation is send our organization, send the HA an email, and hopefully we'll be able to point you in the right direction. Okay. Okay, now we're at 10 minutes left. I'm hoping we can kind of close. We have received a number of questions about bone marrow transplant, BMT. So I'm hoping we can close on that. So again, I wish there was an easy answer to this question, so there may not be, but what is the life expectancy of a child who has successfully undergone BMT for primary HLH? It depends. I don't know.
Normal expectancy, if there has been the immediate period has passed, and then there should be life expectancy as any other child. or any other person. Yeah.
Amazing. Okay. The follow-up question to that is this is a bit more specific. So what is the success rate for bone marrow transplant in infants? And is it better to wait as long as possible before going to transplant? Maybe Dr. Jordan.
Yeah, the success rate that that we typically quote people is about 80% of children that go to transplant survive long term. That's, you know, that can be affected a lot by specific things such as, you know, how suitable is the donor and what are the medical condition of the child going into transplant if they have any special issues or problems. And then, sorry, what was the other half of the question? Sorry.
Is it better to wait as long as possible before going to transplant?
So if you know you need to go to transplant, it's actually better to go as soon as possible. Because the reason you go to transplant is because you expect it's going to come back. And if you wait, right, in other words, if you wait knowing that it'll come back, then that only increases your risk. Oftentimes we do wait because we don't know what the risk is and we're not sure it's worth taking. But if you know you need to go because of the genetic underlying problem, then the sooner you go, the better.
I'm just getting flashbacks to I feel like you're absolutely right in that. I think so often families going through this, especially with young, you know, speaking for myself, having a baby going through this, you know, you really are just weighing what's going to do kind of the least damage. And it seems so counterintuitive to put them through this incredibly invasive procedure, knowing that really that's the best outcome. And it's so, I mean, my heart goes out to any family still kind of in the thick of it, because it really is a tough place to be. And we're so grateful for doctors like yourselves to be able to speak to that and guide us on that, because I think it can really feel like you're between a rock and a hard place. But I will say, if this brings any solace to anybody kind of going through it or weighing things, like, it was really important to me to hear about success stories, especially with the idea of a second first transplant was unreal, unimaginable, and then the idea of facing it all over again with a second transplant just seems so terrifying. But hearing, you know, that's why it's so important, I think, for us to kind of come together and for families to come forward and share these stories, because had I met someone like my family and seen what my son looks like back then, it would have given me so much reassurance, because truly, like, it's incredible the success that is possible. It is possible. So I hope that's okay to share. But yeah, if there's anybody who is, you know, worried about anything or just wants to reach out to speak to someone, please, you know, email our organization. I'm going to ask one last question, and then I'm going to kind of close things off. And I totally what was my question? I just blanked out my question. That's funny. Oh, yes, transplantation. Is it going to be a thing of the past? Is it going to be a thing in the past, in the future? You know, are we going to look back on BMT and think, oh, this is, you know, this is almost barbaric and how invasive it is? You know, what's the future of HLH treatment and bone marrow transplant look like?
Mm-hmm. Well, there's a lot of effort to try to make it more gentle and more effective for patients. And hopefully we can also replace bone marrow transplant with gene therapy at some point. But that's a long, slow process.
Right. Okay. I'm just going to take a quick look to see. Yeah, unfortunately, I think of some of these questions we can't. Oh, if you know about the gene before a flare, do you recommend going to transplant? Oh, to avoid a flare. If you know about HLH before it activates, do you still recommend going to transplant or waiting? That's a good question.
Yeah, it depends on the gene.
Okay.
And it depends on the abnormality. So some genetic problems, we can say with high confidence that they, if they've caused HLH once, they'll cause it again. Others, we don't have as much confidence about. So it's a difficult question to answer in general, frankly.
It's fair. It's fair. I apologize to everybody submitting. If we haven't answered your questions, we just can't do it in kind of a public forum. Please, by all means, email us, and we can work with you. We're just coming up to the end of the hour. I was hoping to close by first and foremost saying thank you for taking your time out of your busy schedules to answer our questions. It was so reassuring to know that, you know, we were able to bend your ear, and we're so grateful for you helping us out with this. I want to remind everybody about the HAC. You know, if you ever need any support, I really believe this. The reason that I became involved, the reason so many of our board members are giving, you know, investing time in this is, you know, we want to be able to help. So if you have any questions and just want to reach out and connect, please, by all means, email us either at info@histio.ca. You can also find us on social media, on Facebook and on Instagram. They're checked often, you know, so there's someone there who can reply. And if there's anybody out there who wants to get involved or give back, we're always looking for volunteers. We're looking for people to share, again, as I said, sharing your stories, you know, at least to be able to show a face that, you know, there are people in this country. We're all kind of spread out, but we do exist, that you're not the only person going through this. So please, you know, let us know who you are, and let's help each other out by continuing to, you know, improve the way that this condition is treated. Does anybody have anything to add before we close off? We got 3 minutes left. Maybe Claudio, do you want to say anything, or Deanna?
Not from our side. Again,
Okay.
I want to thank everyone that participated. Thanks everyone on the phones for participating in this. And again, as a reminder, we're all in this together. The more we can support each other, the better the outcomes we'll have for our family. So I appreciate everyone's time this evening.
Thank you very much. Thanks for inviting me. Thank you.
My pleasure. Thank you so much.
Thank you so much, everyone.
Okay, have a great rest of your evening. Take care.
Bye.
Bye-bye.